Afternoon, everybody. I'm Jan Weisenberger. I'm the Senior Associate Vice President for Research at Ohio State, and I'd like to welcome you to today's CCTS COVID-19 Inventor Showcase. This is a program presented by Ohio State's Center for Clinical and Translational Sciences that over the past year has focused under its Translational Innovation Program on presenting new innovations that have been developed by teams from Ohio State and Nationwide Children's Hospital to directly address a variety of aspects of the COVID-19 pandemic. Today is actually the last of the COVID-19 Inventor Showcase events. Now, I have to tell you that I have been present for many of these showcase events, and I've actually gotten to introduce a few of them. It's been a great privilege. And I want to talk about the series as a whole. And I also want to talk about the pandemic as a whole. So two things I want to talk about today. The first is that the effects of this pandemic on research and innovation have been longer lasting than I think any of us anticipated when this pandemic began. In fact, at Ohio State, we administered a survey to our faculty and research scientists back in April. And we received back almost 1,000 responses from faculty. And we asked about a lot of things related to discipline-specific impacts of the pandemic on research productivity, on people's home arrangements, like were they having to homeschool their kids? Were they having to make alternative arrangements for childcare? We asked a lot of questions about what kinds of programs would help people get back to full productivity. And I will tell you, some of the findings of that survey were rather alarming. Almost 70% of the respondents reported that their research productivity had decreased during the pandemic. In one area of specific interest to the CCTS, our faculty who are engaged in clinical trials research, 20% of them said their clinical trials had not been able to move forward at all. And so as a community, we have catching up to do. We have to find ways to help our faculty get back to the research productivity that then leads to innovation and invention. But I'm also one of those people who thinks that a lot of the things that we have seen during the pandemic have actually been inspirational, and there are some good things. In fact, I think one of the potential bad consequences of the pandemic is if we fail to learn any lessons from it. So one of the things that has struck me about the entire series of the COVID-19 Inventor Showcase is the remarkable spirit of collaboration that we saw from the very beginning, the remarkable spirit of cooperation that people from very different realms of the university and the community all threw in together because we had urgent problems to solve. We saw remarkable inventiveness. We saw a profound sense of urgency. We saw a willingness to cut through the bureaucracy. I mean, that one may be the most amazing one to me. We saw intellectual generosity, people sharing their ideas freely. And we saw something else that I think should always be top of mind for those of us that are part of this great university, which is a renewed sense of our commitment to our community. And these are the things, we don't want to lose that. We don't want to lose that sense of collaboration, that sense of urgency, that willingness to cut through the bureaucracy. And I think that all of the entries in the Inventor Showcase over the last year are incredible examples of just what we can do when we work with a will together. So I want to say congratulations to everyone who has participated in this. and again say what a privilege it has been to be part of this incredible enterprise. Today, I'd like to introduce our last presenting team in the COVID-19 Inventor Showcase. And that team is led by Professor Alper Yilmaz. Dr. Yilmaz is a professor in the Department of Civil, Environmental and Geodetic Engineering in the College of Engineering at Ohio State. The presentation today is a really interesting one because I've known Alper for a long time, and I've known about his research for a long time, and this was new to me that he was working on this. The presentation today is called AI for Handheld Ultrasound Diagnosis of COVID-19. Alper, I'm going to turn the program over to you and have you introduce your team.
Thanks, Jan, for the nice introduction, and welcome everybody. And I'd like to thank you, Dr. Matthew, first for inviting our group to this last talk, and a lot of people behind the scenes that has made this happen. So the talk is going to be on using artificial intelligence and machine learning for diagnosis of COVID-19. Next slide, please. So our team is composed of myself, Dr. Atikari from University of Arizona, Shihan Pereira is a PhD student, and Mike Carnes is a PhD candidate. They are in electrical engineering and civil engineering departments, respectively. Next slide. Okay, so you may ask, it's now 2021 and June, not July. July is coming. So why are we doing this thing, right? So I think important thing here is that the pandemic has not finished yet, right? And this research has not started recently. So I'd like to kind of give a little bit of timeline and talk about why we are doing this research and move the ground over to Dr. Atikari later. So if you look at the progress, we started this last March, more than a year ago. We set up the team, set up strategies to move forward with using our existing research in our lab to solve this problem. Obviously, machine learning requires a lot of data, and we started obtaining this data from online with very low quality data because there was no data at that point that was high quality and being shared by medical centers around the country. So we kind of collected this data across the net and built the initial prototype. At that point, we started getting some initial results, and Dr. Atikari joined our team in June timeframe a year ago, and he provided the medical expertise to this engineering team to actually move forward. And based on this, we did model updates and collected additional data when Mike joined the team, and we had a new solution at that December time point, in addition to our initial results. So then we had papers submitted and papers published. And the good thing about the final product, I think, is that the OSU and University of Arizona made an agreement to share data and techniques between the two universities, which has started a few months ago. And this is going to lead into new research, hopefully in the coming months. Next slide, please. So again, the variants are going on. So that has not stopped yet, right? Hopefully, this is the worst variant is the Delta variant. So we don't see new increase in the cases that are resilient to vaccination. And this severe pandemics are not over. A lot of you know better than I am. I'm an engineer, right? So another pandemic is going to be coming up. So in the 1700s, the duration, the frequency was like every 50 years we had a pandemic. Late 1800s, it was 28 years. So the years halved, right? By the 1960s, pandemics were every 10 years. And by 2000, pandemics were every 5 years. It may not have been at this global stage, but there were still pandemics. So I hope the next one is not going to be 5 years from today, which is going to be 2025, if we go with this timeline. But the next thing is going to be happening. So what we did was to actually develop a system that can adjust to the next pandemic. So that was our goal in this whole system. Right, I'll leave the ground to Dr. Atikari. Thanks.
Good afternoon. Thank you for the introduction, Dr. Gomez. It's been my pleasure to collaborate with you, and I am looking forward to collaborate on additional projects in the future. Before we actually jump into ultrasound, let's take a quick look at the diagnostic testing for COVID. COVID testing is widely available in the US right now. Currently, there are two types of diagnostic tests for COVID-19. One is PCR, the other one is antigen test. PCR actually detects the virus genetic material, and the antigen test detects the specific proteins on the surface of the virus. Antigen tests are not as sensitive as PCR tests. However, all of these tests have some limitations. The optimal time to test for COVID-19 following the exposure is uncertain. All these tests perform really well, the best, when the patient's viral load is generally the highest. In addition, the sensitivity of any of these tests is very much dependent on the site where the swab is obtained and also the technique employed while swabbing. The average turnaround time is approximately 1 to 2 days. So the results are not available immediately to make any clinical decisions. Even though it's widely available in the US, in the resource limited settings and globally, the limited capacity for testing kind of precludes testing all patients with suspected COVID-19. With that in mind, in the next slide, let's take a look at the point of care ultrasound. So what is point of care lung ultrasound? Lung ultrasound performed at the bedside where we can get the results immediately. That's what it is. So point of care ultrasound, the beauty of the point of care ultrasound is it could be done quickly. It can be done by the healthcare providers. Doesn't have to depend on other departments to come over and perform the ultrasound. The other advantages include you're not exposing the patient to contrast or any sort of radiation, unlike other imaging studies. And like I said, you can get the results quickly, and you can correlate with the patient's clinical presentation. Existing evidence as of today shows lung ultrasound has superior accuracy over chest x-rays for the most common causes of all respiratory symptoms. So in the next slide, we'll see, I'm showing you here how the technology evolved. All these recent technological advancements have resulted in miniaturization of the ultrasound devices. And some of them are right now just a pocket or palm size. So the advent of all these devices has created a new paradigm for ultrasound use. Ultrasound has become much more friendlier, less expensive, more affordable. In the next slide, there are a variety of companies who are developing these devices, the handheld devices, and these handheld devices are, they connect to a smartphone or a tablet, which has a dedicated app to perform the ultrasound exam. And these are available widely now. You can buy them, they're commercially available, and they are being used in a wide variety of clinical settings. So in the COVID era, lung ultrasound has become very popular. A variety of lung ultrasound protocols have been described. All of them involve essentially placing the probe on the chest. The variation, the differences between these protocols include whether you're scanning 10 zones versus 12 zones or 14 zones. That's all it is. But everything, all the protocols involve placing the probe on the chest and acquiring lung ultrasound images. So let's look at the normal findings. This is a normal lung ultrasound image. I will not go through all the details of what's on the screen, but just overview. We're looking at the ribs and the shadow beneath the ribs. And these are the findings we use to develop the algorithm, and Dr. Gomez is working on how to develop an algorithm. And then this white and bright line is the pleural line. Pleura is the covering of the lungs. And there are certain lines which come out of the pleural line, We call them A lines versus B lines. A lines are normal. B lines, if you see more than 3 in any specific lung zone, they're abnormal. So what about COVID lung ultrasound findings? Let's take a look at that. So there are a variety of findings which have been described, mostly centered around appearance of the pleural line. Again, that's an important finding. That's where the algorithm focuses on. And also the B-line patterns. How many B-lines are present in a lung zone? So the algorithm can pick up if there are more than 3 lines, okay, this is abnormal. So these are all the findings. And if you see A lines, then, okay, the patient developed COVID, now the patient is recovering. So all of these findings, they're dependent on the stage of the disease and how severe the lung injury and patient had any prior comorbid illnesses and whatnot. However, these are very critical when you're developing an algorithm. So I'll go through quickly a couple of images here in the next few slides. Here is a broken pleural line, which is discontinuous, which is pretty classic for COVID. In the next slide, again, there are what we call the B lines coming out from the pleural line. And in this images, we're seeing multiple B lines in both images. So these are all classic COVID-19 lung ultrasound findings. So what exactly is the role of lung ultrasound in managing COVID patients? It could be used in a variety of ways. It could be used to triage patients, or it can be used to make a diagnosis or prognostic stratification. It can be used to actually manage the patients when they're on the ventilator in the intensive care unit, or you can also use the patients to assess the effects of the therapy you're administering to the patient. There are several case studies out there also suggesting could be used to kind of decide when the healthcare professional actually can come back to work. So the safe timing to discontinue isolation and return to work. Especially it is useful in children and pregnant patients, because we don't want to expose them to any radiation, whether it's a CT scan or X-ray. So we want to minimize the radiation. So ultrasound is a excellent imaging modality to assess these patients or monitor the patients. So in the last year, COVID-19 has been used globally, especially in resource-limited settings. Besides resource-limited settings, even in New York, where in the tertiary care hospitals, when the systems are overwhelmed, when we could not obtain X-rays or CT scans like we wanted to, X-rays, ultrasound became one of the go-to imaging modality in those settings. And also it helped to reduce the exposure of different healthcare providers coming into the room, doing an X-ray, and then going back and go to CT and expose to multiple people to COVID. And it also made it easier to disinfect the probes, as opposed to when you bring the X-ray equipment or go to CT, a lot has to be done to disinfect equipment. So I kind of reviewed how lung ultrasound could be very useful to detect COVID and other lung pathologies in, if at all there's a future pandemic. But to actually distinguish the different lung ultrasound patterns and to diagnose certain lung pathology, you require certain expertise and experience. And that is not widely available. And that is one of the handicaps in the sense that the lack of ability or the skill level of the healthcare provider is one of the principal limitations to use point-of-care ultrasound in a widespread manner. So that's where we are in need of additional technologies to aid inexperienced healthcare providers to interpret the lung ultrasound findings. So, and that's where I believe artificial intelligence or machine learning algorithms come in, and that could be extremely useful for the widespread adoption of point-of-care ultrasound, whether it's lung or other or a different application. I'm going to stop there and turn this over to Shehan at this time.
Hi, my name is Shehan Pereira, and I'm just going to go through an overview of the slides that I'm going to cover. There's going to be an About Me slide, my funded research, which is different from the COVID-related research. And the COVID-related research, I'm going to cover the traditional techniques like Dr. Adhikari just covered, some of the statistics of the COVID research when we first started this project, and alternative testing methods, mobile ultrasound devices, COVID ultrasound, progression and severity monitoring, and I'm going to go into in depth for our actual R&D project where we developed a novel modern model architecture and our experiments and the final results. So about me, my name is Shehan. I'm currently a PhD student in electrical engineering, and I'm also a graduate research associate with the photogrammetric computer vision lab. And previously, I got my bachelor's degree from Ohio State in civil engineering, and my master's degree also from Ohio State in geoinformation and geodetic engineering. And previously, I've worked as a machine learning intern with a defense contracting firm, and for the last 2 years, I have been an intern with Sandia National Lab. So my funded research is a little different from the COVID research. Here, the title of our research is Context-Aware Safety Information Display for Nuclear Field Workers. And here we are combining augmented reality, human factors research, and computer vision to actually help improve nuclear power plant safety for the workers. And our collaborators, we're closely working with Idaho National Lab and Carnegie Mellon University mainly, and we are also associated with Arizona and Duke Energy. And Dr. Yilmaz and I were mostly contributing to the augmented reality and computer vision and deep learning research for this project. Along with the funded research, we have, me and Dr. Yilmaz, we have worked with a medical deep learning research, mainly with the Wexner Medical Center with a neurologist, where we worked on brain hemorrhage detection. As you can see here, where's your pointer? Yeah, as you can see here, the project was about detecting brain hemorrhaging, and not only detecting it, can we identify what type of brain hemorrhaging there is. And with this initial research, we have published a paper, and we have submitted a paper, and also a proposal is also submitted. So because of the lab's capability for computer vision and medical deep learning research, when the pandemic actually started, we were looking at how can we use this to improve or contribute to the COVID-19 research community. And the traditional techniques, like Dr. Adhikari covered, was the PCR technique, which is considered the gold standard by the CDC. However, it takes 4 to 6 hours. And we were trying to speed up this process because the major bottleneck was speed and testing time. And the other modality was CT scans. They're much faster, and there's a lot of data out there for CT, but it requires a long, it requires about an hour to clean the actual machine and the surrounding area. So it's not as effective in when it comes to speed. And some of the statistics when this project started, the total number of hospitals with emergency rooms was 6,100, and there are about 139 million emergency room visits per year, and only 56% of those hospitals actually have access to a CT scanner. And before the pandemic started, the total number of emergency visits for COVID-like illnesses was about 17,000, and for influenza-like illnesses was 19,000. And when this is for March, when it was at its peak, COVID-19 like illnesses went up to 72,000, and influenza like illnesses went up to 62,000. And the whole point is that it took about 7% increase in emergency room visits to crumble the healthcare infrastructure. And this is where these alternative testing methods come into play, because a lot of doctors start adopting the mobile ultrasound because it's a lot faster, and you can set up mobile stations and actually carry out rapid testing. And there are many countries that were shifting towards these handheld ultrasound devices because they directly connect to your cell phone, and it's very portable. And the process takes under 13 minutes. However, this 13 minutes includes a highly trained doctor. And because there are clear features, like Dr. Adhikari covered, deep learning and computer vision algorithms can actually learn these features without any human supervision. And because of this, we can actually take this trained model, or take this algorithm and embed it into an app where any untrained worker will only need to scan a patient, and we can detect if there is COVID-19 or if there is pneumonia in that patient. So there are many ultrasound devices. Very common ones are Butterfly, IQ, and GE, and a lot of people make it. But each they don't really give you a set of algorithms, because they want a doctor looking at these ultrasound data. And this is great for many cases, but it's not good for rapid and mass testing. So our research covered pneumonia, because pneumonia is caused by COVID-19 and is clearly distinguishable. I'm not going to cover these because Dr. Adhikari covered these. And these features, however, can be learned, and which is what we saw from our research. And additionally, we can, given data, we can actually monitor the progression of COVID-19 or pneumonia. And so our unique approach, we use the latest development in deep learning, which are transformer models. And this is an image of a transformer model. And in particular, we used a vision transformer, which allows us to use transformers on image data. And the original vision transformers are large, and it requires a lot of computational resources. Like, for example, the base model for the vision transformer is about 86 million parameters. And they put out 3 models: base, large, and huge. And the base one is 86, and the largest one is 632 million parameters. This is not ideal for a mobile scenario. Like, if we want to embed this into an app, a cell phone is not going to be able to carry out this computation. So our research, we were trying to shrink the model and still have a really good final accuracy. And to do this, we replaced the internal transformer architecture with a linear transformer, which allowed us to bring down the parameter count to 2.8 million parameters for a binary classification model, and 6.9 million parameters for a multi-class classification model. And this is the overall architecture of our model. We have our ultrasound image, which comes in, and we split it up into 9 patches. And each patch is we linearly we kind of embed these patches into a vector, which is passed into our transformer, and then we finally take the output and we classify this output using another neural network. So the experiment, we covered binary classification first, just to see if we can get really good performance out of it. Binary classification meaning COVID-19 versus pneumonia can be differentiated the two, and COVID-19 versus healthy, and healthy versus pneumonia. And when we take a look at what the model has actually learned in the final layers, we can see that the model is able to clearly distinguish between COVID-19 and pneumonia, and healthy versus pneumonia, and COVID-19 versus healthy, because we are able to actually take an image and split it into two separate groups. But the binary classification model is not that useful in real life, so we actually went to a multi-class classification model. Yeah, this is the final result of our of this particular research. The performance results for our model, it outperforms recent published COVID-19 detection research, and it also outperforms standard black box convolution neural networks that anybody can apply. On top of that, our parameter count is very low. So our final results, these are our final results. Yeah, just nothing much to cover here. Just we're doing really well. We're in the mid to high 90s across the board for all the metrics that we were actually looking for. So I'm going to hand it off to Michael Carnes, and he's going to cover a little bit more about his research, which is another model, another architecture that he developed for COVID-19.
Thank you, Shihan. So I'm going to start with a little bit about my research path and how we came to this current project. So I started my undergrad in mechanical engineering and had some experience with some medical device development during that time. Found a great research group for my master's degree that looked into electrically characterizing tissues for medical devices. That's where I actually met my current advisor, Dr. Alper Yilmaz. And he's in the civil engineering department where I'm doing my PhD, looking into visual tracking, recognition, segmentation, and few-shot learning, in general, image processing for semantic information. And so my main project is visual object tracking for the Air Force Research Labs. And so this basic process, we use concepts to describe images. And people say images are worth 1,000 words. So we arrange this problem into different types of tasks. So there's three main tasks that visual object tracking tries to tackle. First is the classification of the image. What is the image of? And so an example of this is the image to the far right of the slide is an image of the player in the number 4 jersey. This would be a description of what the image was. It was of a player. Recognition, who is the image of? So it's the image of the player in the number 4 jersey. And then the next question is, where is this person in the image? And so yeah, this is our basic, the task that we try to tackle in visual object tracking. Next slide, please. And so we noticed that this type of algorithm was similar to that used for COVID diagnostics in these ultrasound images. We had the same basic questions. Does this image contain COVID-19? Can we see where this COVID-19 symptoms are located? And then can we compare these over time and relocate these? So tracking the COVID symptoms instead of the basketball player. And so once we saw this crossover, we thought it was part of our research duty to try to apply these technologies to tackle the pandemic of COVID-19. So as Dr. Adhikari, go back please, had said, diagnosing COVID and pulmonary diseases in ultrasound images in general requires significant training. It's not straightforward. And as a result, not all hospitals are able to have ultrasound specialists available to make these kind of diagnostic decisions. And so what our project aims to do is to extend the expert knowledge of these ultrasound diagnosticians to more point of care settings where they were previously unavailable. Next slide, please. And so this algorithm is set up in a basic input-output manner. So to start, we input a set of reference images, and these are images that have been labeled by the pulmonary specialist. We then train our algorithm on these set of reference images to detect if the image has COVID or is normal, has pneumonia, or is pneumonia or COVID. And once this is trained, we then input a query image, and our algorithm outputs decisions for each of these questions. Next slide, please. We use a technique called a dictionary recognition. So these reference images serve to train our dictionary. And we use dictionary recognition every day. How we classify animals is a dictionary recognition. We use a set of features or a specific definition, description, or signature to denote what is a certain breed and what isn't a certain breed in terms of goldfish or dogs or cats. And so in a similar manner, we create definitions of COVID and non-COVID, or of disease states in general. So we have like the normal disease state definition. We have the COVID disease state definition. And with these definitions, we can then recognize or classify new images by comparing them to our known definitions. And so once our algorithm has learned these features, it can then also be used to look at or segment the ultrasound images into different likelihood regions or regions of interest. So you could use the COVID definition to highlight where the COVID-related symptoms are occurring or features are occurring. And so the images on this right show the heat maps of where the algorithm thinks these symptoms are, and they correlate with alterations in the pleural linings. So we can use this algorithm not only to classify a novel algorithm as COVID or non-COVID, but we can also use it to help direct healthcare providers on interesting regions in the image. So help them with that diagnostic process. And then there's also the possibility that this visualization is able to pick up on features that were previously unseen or missed by the naked eye. So it could help with the robustness of that diagnostic survey. Next slide, please. And so one of the main questions we had for this algorithm was, how many images do we need to train this? Because if we want to apply it on a mass scale, it has to have efficient adaptability to the current settings, so to the device, to the operator, to the individual. And so we wanted to know how many images are required. And so we looked at training this algorithm on 16, 32, 64, and 128 images with ultrasound devices operating between 10 and 30 hertz. This was in like the 2 to 10s of seconds worth of data collection. So you can relate the number of images also to the length of the data sample required. And we also looked at convex and linear ultrasound images. And we found that the linear in general was a better imaging modality for this algorithm, producing very high accuracies in the blue in these plots, almost 1% or 100% with just 16 images. But the convex was still also useful in diagnosing, but required more images. And so this is kind of our results on the accuracy of our algorithms performance. And so the product description, how we want to implement this product, or how it would be used, or how it's imagined to be used in this point of care setting. And so when the diagnostician takes an ultrasound image, these images would be transferred to the local computer, because this algorithms also ran on pre-trained minimalist networks that enable local running on like local desktops. So you can run this on your average computer, and the algorithm will input this clip of the patient's ultrasound images. And from those images, the clinician would be able to see regions of interest detected, disease state estimations, as well as disease state tracking. So you can track the progression of the diseases by comparing their definitions day to day. And so we see this as an aid in handling general pulmonary diagnostics using ultrasound images. Next slide, please. And so this algorithm took a lot of people to come together to get it done. So first, I'd like to thank AFRL for sponsoring my research in visual object tracking in the Ohio State University, for providing me the incredible resources to collaborate with such a talented team to get this done. The CEGE department, the PCV Computer Vision Lab, Dr. Yilmaz, my mentor, and Dr. Adhikaris at the University of Arizona. And now my mentor, Dr. Yilmaz, will wrap up this current project on the COVID point of care ultrasound diagnostics.
Thanks, Mike. So as you had seen, we talked about two different techniques here, and the purpose of developing these techniques were not the same, they were different. So the second talk Mike talked about is in cases when a new pandemic starts and you have really very few images actually with expert knowledge provided to you. So we don't have a large corpus. We have very few images, maybe 10, maybe 20 images. And you like to start off an artificial algorithm, artificial intelligence algorithm that can actually start making diagnosis immediately. And as you had seen, the results are pretty accurate for having very few images. On the other hand, as time progresses, once we have actually enough number of images to generate a large corpus of training data that can be used to train a better system, then it goes to Sheehan's approach, where we actually reached all the way to 99% accuracy. So next slide, please. There's this feature table here against all other techniques at the time that we were evaluating our approaches. And pretty much our goal was to come up with a technique that doesn't require trained people like doctors in remote parts of the world or in places where there are no CAT scan machines or large labs. So our approach can handle that, and a paramedic simply can take these images. And a platform is a mobile platform versus lab, hospital, or other kinds of setting. Image acquisition time, data acquisition is very small. Diagnosis time is less than a minute, and sanitization is just changing the plastic wrap around these devices, less than a minute. And there's other features that you can see here, and the cost is very low, which is the sanitization bag and the algorithm running on the device, less than $20 compared to higher prices on alternatives. So we are looking at this as a potential product in the future for this or for the next pandemic, with high reliability, no radiation exposure, and a possible extension to being able to stage the disease. Right, thanks.
Hi, good afternoon, everyone. I'm Allison Mckay. I'm the chair of the Civil, Environmental, and Geodetic Engineering Department, from which this excellent work that we've heard about in the showcase today has come. And it's just a wonderful example of how techniques that are normally used to make measurements of the Earth's surface can be brought to bear directly on medical diagnoses. So I have a couple of slides today that I will just highlight some additional potential for intersectionality with the medical community by showcasing or mentioning some research initiatives that show how civil and environmental engineers are deeply involved in public and community health. So in the context of healthy water systems, we have a number of researchers who are working to understand how chemical and biological contaminants move both in natural water systems and also in engineered treated water systems. And we use a number of different really cutting edge analytical tools to answer those questions. I will highlight that some of the other COVID work happening in our department is the statewide wastewater epidemiology that's happening around the SARS-CoV-2 virus. That's all being coordinated out of work that's happening in the CEGE department. We also have work going on to understand healthy air systems. As we've been moving towards having more energy efficient buildings and thinking about less resource use when we make green buildings, for example, there's some changes on the air quality in those buildings. And so we've got a number of researchers who are trying to come up with similar low cost techniques, much like the ones we heard about today for the lung imaging, but to answer different questions that would enable more broad-based monitoring across housing systems. And then finally, for much of the design that civil engineers engage in, we always want to be thinking broadly about community disparities. Coming up with designs that will alleviate disparities that currently exist, but also are making designs for full engagement of folks, no matter, these usually primarily fall out along socioeconomic means, but we also know that in urban areas that also has got a race and ethnicity dimension to it as well. So understanding how people make decisions about their means of transportation to destinations that they want to get to, understanding how to ensure that the physical infrastructure of the power grid will bring power to people's houses, no matter what zip code they live in, and that they'll be protected against flood events. And so particularly looking to the future as we're thinking about having more renewable sources of energy, are we engaging all of those people in those activities? So a lot of this work is happening more with social science type tools, and all of this together, put the next slide, Mike, or she had, thanks. So all of this together, we hope is bringing better design to help to support the protection of public health and ensuring that we've got safe and reliable infrastructure in both our urban and rural areas. So I have my contact information here. I'm happy if you would like to reach out, either both for kind of making the intellectual connections or for some of the technologies that we have available in our labs. And I'll turn the last word back to Alper Ilmaz again, who will highlight a little bit more about the actual capacity that he has within his research group.
Thanks, Allison. I'd like to be brief. We can go to the next slide quickly, Shihan. Thanks. So we have been having support from different DoD departments, as well as NASA, NSF, and James Center, and different industry companies that you see here. Next slide, please. So next slide, we'll skip this. Okay, so our focus in our lab is how to acquire data, how to combine different sensors into an integrated solution. And around this thing, we design algorithms that are supervised, unsupervised, deep learning, reinforcement learning, and so on and so forth. So we have low-level analysis of these data that's collected and analyzed through the algorithms that we develop. We also do a high-level inference. So in low-level analysis, we come up with decision-making, the clustering, mining, detection, tracking, etc. While on the high levels approach, we actually perform decision support and semantic labeling, anomaly detection, and etc. And you can go to the last slide, Shihan, from here. You can go, yeah, last slide. Okay, so my contact information is here. I can answer anything you like about the work that has been presented here, or any other work that has been going on in my lab over the past about 16 years. Thanks a lot.
Hi, I'm Bruce Weinberg. Dr. Mckay.
Oh, no, go ahead.
I was just going to start the question
Yeah.
and answer. Okay, great. I want to first of all thank everyone for and maybe invite folks to turn their videos back on, to thank everyone for just a really amazing set of talks. Showing how different technologies can be combined in a way that at least I couldn't have fathomed before I was hearing it. We have one question in the Q&A that has only been partially answered. So I was thinking maybe Dr. Adhikari could talk about whether the method could be applied to influenza as well as pneumonia, which came up as part of the the presentation.
Yes. So the question is whether lung ultrasound could be used to diagnose other conditions like influenza or pneumonia. Pneumonia meaning bacterial pneumonia. The answer is yes. However, I would start saying that there is some overlap between the lung ultrasound findings for all these conditions. Having said that, there are certain very classic features for all these lung conditions, meaning if you look at COVID, what we see with the pleural line abnormalities are very classic and typical for COVID. So you can tell the algorithm, if you see this broken pleural line and thick pleural line, it is more likely going to be COVID rather than classic bacterial pneumonia. On the other hand, if you see bacterial pneumonia, you will have like what we call air bronchograms, meaning there's fluid accumulation within the terminal bronchioles. So that is pretty classic for bacterial pneumonia. So you can tell the algorithm, if you see something like this, it's going to be more likely bacterial pneumonia. And I can go on and on. For influenza, there's a different B-line profile, whatnot. So Alper can definitely comment on this. But you can tell the algorithm, if you see the pleural line abnormalities, the likelihood of having a COVID is about 90%, but only maybe 5% bacterial pneumonia or 3% heart failure, something along those lines. So the answer is yes. There are certain features which are very classic for certain lung conditions. So you can train the algorithm based on those findings.
I agree. I'll just add one more comment on Dr. Adhikari's explanation. So the good thing about machine learning is the features that are extracted from these kind of images are not engineered. So it can see the things that the expert sees. It can also see the things that the expert might not be able to observe because of the combination of different things that are appearing in the image content. So from that perspective, I think a comparison between pneumonia and COVID, which kind of lead into about 95% to 96% accuracy, kind of showcases that, yes, they can be differentiated. There's always going to be cases that are overlapping, as Dr. Adhikari explained, but hopefully the algorithm will see additional features that we might not be able to see.
I think another question that came into me directly, and people feel free to ask additional questions in the Q&A function, was whether there's the potential to identify conditions that, sort of while you have these images, to identify conditions that simply might not have even been on that you were looking for. I don't know if you have thoughts on that.
So I claim no expertise in this. I would have Alper answer this, but from what I understood and learned from Alper is that is the beauty of reinforcement learning. If I understood right, things we may not be familiar today with the, hopefully not, but an upcoming pandemic. So the algorithm would see already familiar with all these other lung ultrasound findings of existing diseases. Now it sees these new findings and keeps seeing these new findings in one patient, second patient, third patient. Then it starts saying, hey, this is new something, so we need to work on this. So that's how I understood from Alpera, and that was really exciting to know that the algorithm could function that way.
That's correct. So we haven't talked about that research that's also going on in the lab in this particular presentation, but we're working on algorithms that are kind of intelligent enough to figure out if something new has started. So in order to do that, we are developing these reinforcement learning algorithms that in the base contain some of the things that you had seen here, but it also contains additional framework that has a reward and punishment mechanisms to see if the diagnosis or the new pandemic, let's assume, or a new disease being started is a correct assumption that the algorithm is making or not. So by introducing an expert into the picture. But yes, that can be done.
Great. Well, I want to thank you. There's an additional question in the Q&A that maybe you guys can type an answer to. I'm going to turn things over to my colleague, Carolyn Christofouli, for some concluding remarks.
So there is a question I seen, AI field, like the cybersecurity aspect of the problem. Just say one sentence on this. So yes, the research on the cybersecurity aspect is recently picking up on this particular area. And there are actually algorithms that can attack machine learning diagnosis. For instance, in this case, you can change a number of pixels in an image and can make the algorithm fail because the machine learning didn't learn the algorithm from that perspective. So what can be done is, that's what actually our research has been moving towards into, is to develop that additional intelligence into the machine learning, where it can start figuring out if there is an attack going on, or if there's the attack being changing the image content, attack being trying to access the patient data, for instance, to kind of figure out if that's happening. And if that's happening, it blocks or adjusts the learned machine learning tools to answer that particular problem.
Excellent. Thank you so much for that. And any additional questions, please feel free to reach out to the panelists. There's so much to cover. I'd like to extend a special thanks to Jan Weisenberger for starting us off, and especially to our presenting team, Alper Yilmaz, Shikhar Adhikari, Michael Carnes, and Shihan Pereira, and also Allison Mckay. Thank you all for sharing your fantastic work today. The COVID-19 Inventor Showcase, part of the CCTS Translational Innovation Program, or TIP, is co-presented by the OSU Corporate Engagement Office and Nationwide Children's Office of Technology Transfer. We would also like to thank our mission partners. For more information regarding any of the partners or how to become a mission partner, please contact Tanya Matthew. These unprecedented times inspired our CCTS Inventor Showcase to pivot and focus on amazing work being done within the OSU and NCH communities to address COVID-19. Next month, we will resume featuring innovation and invention across all health sciences. We hope you will join us for the next CCTS Inventor Showcase on July 13th, featuring George Underko, John Bertrand, Manaj Ramachandran, as they share their work on a medical mobile billing app. The CCTS and COVID-19 Inventor Showcase is supported by the CTSA from the NIH National Center for Advancing Translational Science. Again, thank you everyone for joining us today. We hope to see you next month.